Assalamu alaikum and good evening to all. My name is Dr. Misbah Manzoor and I am working as a senior registrar in Department of Cardiac Imaging in Peshawar Institute of Cardiology. I am obliged to be here. Today I'll be talking on the echocardiographic evaluations in patients who are suffering from hypertrophic obstructive cardiomyopathy. So a little insight into the background of the disease. Hukam was initially described by Thierry in 1958. However, it was first of all clinically diagnosed by Braunwald in 1960s. The disease is predominantly prevalent in men and African Americans with a ratio of 2:1 and with the overall prevalence of 0.05 to 0.2% in general population. Moreover, it is the leading cause of sudden cardiac death in adolescents and pre-adolescent children. An autosomal dominant inherited disease that is difficult to define precisely and concisely because of a variable penetrance and expressivity. But to sum up, it is defined as an unexplained, marked, mostly asymmetrical, but it may be symmetrical, localized, or maybe the generalized left ventricular hypertrophy that is associated with non-dilated left ventricular cavity in the absence of another cardiac or systemic disease that may lead to pressure overload condition or infiltrative state. So keeping in view the context of today's conference, I would like to concentrate my talk on the echocardiographic parameters that must be sorted out in the patients with Hukam. As an echocardiographer, in order to establish a complete diagnosis, for complete quantification and for the prediction of a possible prognosis, so a systemic approach must be followed in patients who are known or suspected to have Hukam. So step-by-step approach, starting from the first step, going to upward to the last step, all of the steps will help us in diagnosis. The first step is confirming the presence of left ventricular hypertrophy. So the location and extension of hypertrophy in Hukam is very versatile. It preferably involves the basal part of the anterior septum, but it may involve other areas of the left ventricular wall that includes the lateral wall, posterior septum, and apex of the LV cavity. 2D echocardiography is the first line imaging modality for identification of this very basic pathology. So American Society of Echocardiography has proposed some guidelines to diagnose a patient with Hukam. First of all, an unexplained maximum wall thickness of more than 15 millimeter in any myocardial segment or more than 13 mm in patients with the first degree relatives confirmed with Hukam. The other parameter that is used to define the increased LV wall thickness is septal to posterior wall ratio. The cutoff value in normotensive patients is 1.3, and in hypertensive patient it is more than 1.5 mm. Some of the top tips for echocardiographers that the measurement of left ventricular wall thickness should be done at all the levels, in all the segments, and during end diastole. The more suitable levels are at the level of the mitral valve leaflet tips, mid LV cavity, and apical levels. So this is the pictorial depiction of different forms of and distribution of hypertrophy in the LV cavity that we mostly encounter in patients with Hukam. Initially, you can see in the figure A, there is a selective hypertrophy of the septum that is involving majorly the basal portion of the septum. In the second diagram, the figure B, you can see a concentric involvement of the LV cavity. The third diagram represents the predominantly the apical hypertrophy in the patients with Hukam, and the fourth representation is the presence of sigmoid septum that is majorly involving the anterior portion of the septum. So this picture depicts the importance of underlining the true endocardial border to correctly and precisely measure the left ventricular wall thickness. The dotted lines that you can see is the overestimation of left ventricular wall thickness because of falsely including the trabeculations or aberrant papillary muscles in measurement of the left ventricular wall thickness. However, they are not the true contributors or the true components of the left ventricular wall thickness. So these mistakes may lead to overestimation and a wrong diagnosis. So they must be avoided and kept in mind while taking this measurement. The second step is the assessment of LVOT obstruction. This is the most important step, and it needs to be determined because it is responsible for the symptomatic presentation of the patients with the disease, and it will alter the management strategies. So as I've said earlier, it is an independent predictor of prognosis, a major contributor to the symptoms, and will affect the management strategies. So the ASC has recommended a cutoff value of more than 50 millimeter of the mercury, a gradient that may be present at rest or with provocation maneuvers that mandates a surgical or percutaneous intervention if the symptoms cannot be controlled by conservative or medical treatment. So this is the typical picture of a Doppler signal that we get. You're quite familiar with it. It's a dagger-shaped signal with a late systolic peaking. So the obstruction in Hukam in 1/3 of the patient, they can have the gradients at LVOT even in the resting conditions. In next 1/3 of the patients, the gradient may be provoked either by the physiological or pharmacological maneuvers. In rest of 1/3 of the people who are known to have non-obstructive form of Hukam, there may be no gradient even at rest or even with provocation. The normal provocation maneuvers that are used at bedside and in echocardiography are Valsalva, exercise, and standing. Pharmacological maneuvers are not indicated unless the patient has a limitation to exercise. However, the most closest pictures of the development of the symptoms is given by the exercise. So this is the pictorial depiction of the augmentation of the gradients as a result of different maneuvers. You can easily see that the gradient at the rest has been augmented as a result of performing the Valsalva maneuver. And this is the increase in the gradient secondary to the exercise. So in this step, the top tips for the echocardiographers is that, as we know that LVOT obstruction in Hukam is dynamic, and it changes with different loading conditions. Any of the drug or any condition that leads to change in the myocardial contractility, ventricular volume, or afterload will cause a decrease or even in the elimination of the gradient. And whenever we are detecting the gradient and reporting it in our echocardiographic reports, it is very important to tell the exact site and quantification of the gradient. It should be differentiated that whether it is an apical form of Hukam causing an apical gradient or mid-cavity gradient, and it must be differentiated from the fixed gradient that may occur as a result of fixed obstruction, such as in the case of presence of subaortic membranes and other pathologies. The third step is determining a very pathognomic feature of Hukam, that is SAM, systolic anterior motion of the mitral valve leaflet. So there are different mechanisms that predispose to this phenomena. As we know, because of the presence of septal hypertrophy, there is an hyperdynamic EF that drags the anterior mitral leaflet into the LV cavity. Secondly, the Venturi effect that occurs because of the flow acceleration established because of the flow of the blood into the narrow LVOT, provides a negative suction pressure for the sucking in the anterior mitral leaflet. And third, and the most important and mostly ignored, is the presence of intrinsic morphological abnormalities of the mitral valve apparatus. These are the factors that contribute to the systolic interior motion of the mitral valve leaflet. So whatever the pathology is, SAM of the mitral valve results in the failure of coaptation of the leaflets that will result in mitral regurgitation. However, mitral regurgitation secondary to the SAM has certain characteristics. It will be eccentric, mostly posteriorly directed, and will occur in mid to late systole. However, if in the patients with Hukam you find a concentric or anterior jet of mitral regurgitation, so other intrinsic mitral valve abnormalities must be sorted out. And where comes TEE, because it is more sensitive and specific for detection of these abnormalities. So this is a Plaque's view that is showing the anterior motion of the mitral valve leaflet, SAM. The same has been depicted on M-MOD echocardiography that is showing a septal and anterior mitral leaflet connection. Here, the SAM is causing an obstruction and turbulent flow within the LVOT cavity and also resulting into the concentric posteriorly directed jet of the MR. So these are the abnormalities that are frequently encountered in the patients with Hukam regarding the mitral valve leaflets, chordae, as well as papillary muscles. These are important to point out and to report in your final report because they will alter the surgical techniques and they may cause the extension of surgical procedures. The most common one of them is elongation of anterior mitral leaflet. If a patient with HOCM presents to you with the AML elongation and you have diagnosed this preoperatively, then it may mandate the surgeon that he should do the leaflet plication in addition to septal reduction. The chordaes are often elongated, lax, or hypermobile. The most common abnormalities in papillary muscles are they may be hypertrophied, bifid, they may be abnormally anteriorly placed, or they may be directly inserted into the anterior leaflet. In any of these abnormalities is present, so it will definitely change your surgical management. So this is the presentation of different morphological abnormalities. As you can see in the first diagram, there is a direct attachment of anterior papillary muscles into the anterior mitral valve leaflet. Figure B, C, and D shows the hypertrophied papillary muscles. They are adding into the LVOT obstruction and increasing the gradient. The last figure shows the abnormal muscle band with attachment to the septum. So all of these abnormalities are important to address and correct in order to get the relief of LVOT obstruction at the end of the surgical procedure. So these are different other features that are encountered in the patients with HOCM. There is early systolic closure of the aortic valve, or there may be the fluttering of the aortic valve leaflet, and fibrotic changes that may occur as a result of the contact with the septum. Up till here, we have discussed different parameters in order to diagnose the HOCM. From here, these parameters will tell us the probable prognosis of the patients that are diagnosed with HOCM. So assessment of systolic function is important as it will predict the possible prognosis of the patient suffering from the disease. So it is divided into the two stages, an early stage and a later stage. In the early stage, if we take fractional snorting or ejection fraction as the parameters, so we will have a normal or supernormal systolic function. But because of the presence of significant impairment in longitudinal contractile function, the strain or the strain rate are the correct parameters that should be used in order to diagnose the subclinical systolic dysfunction. And they are also good correlated with the exercise capacity of the patients. The second part of the disease, that is the terminal or called as a burnt out stage of the patients with the HOCM, they may cause a progressive impairment of systolic function as a result of the fibrosis and thinning of the cavity that will result in dilatation, and this is called as end stage HOCM. The importance of determining this stage is that it will cause an increase in mortality to almost 11% per year and increased rate of sudden cardiac death in patients with HOCM. So here you can see a parasternal long axis view showing the septal hypertrophy, and in the second diagram you can see the reduction in the strain in the septal portion. Similarly, here is the hypertrophy of the LV apex, and you can see a reduction in the longitudinal strain in the septal portion of the patient. This is also a decrease in the longitudinal strain with basal to apical gradient in the patients with HOCM. The next parameter is determination of diastolic dysfunction and NA enlargement. So diastolic dysfunction is a very pertinent feature of the patients with HOCM, and it is present even in the absence of systolic dysfunction or even in the absence of LVOT obstruction. It is important to assess because it will help us in evaluation of the symptoms and staging of the disease. And the normal parameters as discussed earlier of diastolic dysfunction are also applicable in HOCM, including the E to A ratio that will show a restrictive pattern, an increased E to E prime, a decrease in the septal and lateral annular velocities. So this is the different ratios that are present in the patients with HOCM. LA enlargement, it is a very important predictor because it will not only predict the poor prognosis, but also will cause an increase in the sudden cardiac death. The different pathophysiological mechanisms for LA enlargement includes presence of MR, diastolic dysfunction, and atrial myopathy. However, American Society of Echocardiography has advised to take left atrial volume indexed with the body surface area. This parameter, if it is more than 34 ml per meter square, so it will predict adverse cardiovascular outcomes. Different neuroechocardiographic techniques have been also adopted in the patients with HOCM that will aid us in diagnosis and help us in managing the strategies to treat. 3D echocardiography is the topmost in one of them because it gives us an insight into the mechanism of SAM and deformational geometry of the LVOT. Contrast echocardiography is important where we have to look for apical hookup and apical aneurysms that are easily missed after that. Okay. And especially for the septal alcohol ablation. In that case, the delineation of the septal perforator is very much helped with the contrast echocardiography. TE is also important where you have inappropriate transthoracic windows or where you have to assess morphology of mitral valve.
Yes.
Okay, thank you.
Thank you
Questions?
so much, Misbah. Actually, I just wanted to say very well done. It was actually my talk, but I wanted Misbah to present. We do want our junior colleagues to step up, and she has stepped up very nicely. So I think that should be the way to go. We need many more junior colleagues, many more female colleagues to be in the field of echo, and very well done to Misbah. I don't have any questions, and I'm sure the seniors will be very kind to her.
Actually, I've got a question, Dr. Abid. Are we doing this septal ablation in your setup? For the
I've done
especially
some
for the
of
hookup.
Yes, I've done some of them while working in the UK, but we haven't got any setup here. That's going to be our next step in our structural intervention anyway. So yes, that's our next plan. And inshallah, we'll be doing them in the next
because we are not doing an AFIC, and we have got a couple of cases who managed to get into the operation theater for replacement of the aortic valve and replacement of the mitral valve, and it was actually a Hookham patient.
All right.
So unfortunately, it was probably more than 10 years back, but nowadays this do not happen.
So we have got a couple of the patients lined up. The main issue for us is getting the 100% alcohol for that. Otherwise, we have got the expertise and we have got the infrastructure to do them. So hopefully, inshallah, in the next couple of months, we'll be doing some of them. And we can always collaborate if
yes.
there's. Okay.
Okay, thank you very much.